A 25-year-old man with recurrent pneumonia. These are the images. What is your diagnosis? Contrast-enhanced thoracic computed tomography. Mediastinal window and lung window images demonstrate a well-defined cavitary lesion in the left lower lobe and an abnormal vessel arising from the lateral aspect of the distal descending thoracic aorta, adjacent to the cavitary lesion. An abnormal vein anterior to the aorta is also present. Differential diagnosis: pulmonary sequestration. A parenchymal mass or cavitary lesion in a lower lobe with systemic arterial supply and systemic venous drainage is characteristic of a pulmonary sequestration. Lung abscess. A lung abscess in a lower lobe can present with an appearance similar to that of a pulmonary sequestration. Key elements for differentiating between these conditions are the vascular supply and drainage of the abnormality. A pulmonary abscess in a previously normal lung should have a normal pulmonary supply and normal venous return. Intrapulmonary bronchogenic cyst. A bronchogenic cyst, when located in the pulmonary parenchyma, can also resemble a pulmonary sequestration. Again, the vasculature helps in distinguishing between these abnormalities. Pulmonary sequestration is an anomaly of tracheobronchial branching, with an abnormal bronchial connection or obstruction and abnormal systemic arterial supply to the affected lung. Common clinical presentations include pneumonia, recurrent infection, cough, and hemoptysis. Bronchiectasis, atelectasis, air fluid levels, and emphysema in the sequestered lung are common. Classically, pulmonary sequestration has been divided into two major categories: intralobar and extralobar. Intralobar sequestration is the most common type, 75%, may affect either lower lobe, is likely congenital, and is surrounded by visceral pleura. Some cases of intralobar sequestration are probably acquired as a consequence of bronchial obstruction and receive arterial supply from the descending aorta. Extralobar sequestration is likely congenital, is seen predominantly in males, and commonly presents relatively early in life. The vast majority of extralobar sequestrations are located in the left lower lobe, in 90%. An extralobar sequestration receives its arterial supply from either the thoracic or the abdominal aorta. A large number of extralobar sequestrations are associated with other abnormalities, such as left posterior diaphragmatic hernia, congenital heart disease, and congenital cystic adenomatoid malformation, or they may be connected to the gastrointestinal tract, esophagus or stomach. Intralobar sequestrations have venous drainage through the pulmonary venous system, whereas extralobar sequestrations have systemic venous drainage through thiazygos vein, hemiazygos system, or inferior vena cava. On conventional radiographs, pulmonary sequestration can have a wide spectrum of imaging findings, including a solid mass, a cystic lesion, and an air fluid level, which can be confused with pneumonia, abscess, cyst, and tumor.